Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 423 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, BJB is a 55-year-old man with newly diagnosed, locally advanced head and neck cancer. His planned therapy includes cisplatin and fluorouracil given with concurrent radiation for a total of 6 weeks after surgical resection. A review of systems suggests that BJB has poor oral hygiene, and a decision is made to consult the dental department of the university hospital before initiating radiation and chemotherapy. So my questions to you are: is BJB at risk for experiencing oral complications of chemotherapy? Is there anything that should be completed at this point to decrease his risk? BJB is at high risk for several of the oral complications previously described. Xerostomia, one of the most frequent side effects of radiation therapy to the head and neck, occurs secondary to radiation-induced changes to the salivary glands. Evidence supports a direct relationship between the dose of radiation to the salivary glands and the extent of glandular changes. In most patients treated with less than 6,000 radians, which refers to the radiation-absorbed dose, radiation-induced changes to the salivary glands are reversible within 6 to 12 months after the end of therapy. BJB will also be receiving chemotherapy agents, i.e., cisplatin, that can cause xerostomia and enhance the toxicity to the salivary glands. Clinically, xerostomia has been caused by as little as 2 to 3 radiation doses of 200 radians. Damage to the salivary glands causes various effects, including a loss of salivary buffering capacity, lower salivary pH, no mechanical flushing, decreased salivary immunoglobulin A, and reduction of saliva production. In addition, xerostomia can alter the sense of taste, causing some patients to lose their ability to differentiate between sweet and salty foods and others to report a bitter taste. Xerostomia also commonly causes caries. Caries and decalcification may become sufficiently severe to compromise tooth integrity and cause fracture. Because saliva is no longer available to help clear bacteria from the mouth, xerostomia also predisposes patients to infection secondary to the increases in oral bacteria. We will now briefly look at treatments and prevention. Amifostane, an organic thiophosphate chemoprotectant agent, is approved to reduce the incidence of moderate to severe xerostomia in patients having postoperative radiation treatment for head and neck cancer. Guidelines published by ASCO support the use of amifostane to reduce the incidence of acute and late xerostomia in patients receiving fractionated radiation therapy without concurrent chemotherapy for head and neck cancer. However, amifostane is not widely used due to its cost and adverse effect profile. If xerostomia occurs, treatment strategies can include stimulation of existing salivary flow and replacement of lost secretions. Relatively low doses of systemically administered pilocarpine, dosed at 5 to 10 mg orally 3 times daily, may stimulate salivary flow and produce clinically significant benefits in patients with post-radiation xerostomia. Results demonstrating pilocarpine's benefit are inconsistent. Dose-related adverse effects include cholinergic effects, such as sweating, rhinitis, headache, nausea, and abdominal cramps. A review on the oral complications of cancer therapy suggests that cevimeline, dosed at 30 mg orally 3 times daily, and bethanacol, dosed at 25 mg orally 3 times daily, may have fewer side effects than those seen with pilocarpine. Sucrose-free hard candy and sugar-free chewing gum can also stimulate salivation, but these treatments are typically considered oral comfort agents. Saliva substitutes can also provide oral comfort to patients with xerostomia. Commercially available saliva substitutes generally are recommended for use before meals and at bedtime. They are available in several formulations, including sprays, rinses, and chewing gums. Patients who find one product or formulation unacceptable or unsuccessful may benefit from experimenting with other formulations or product lines. Studies have shown that salivary substitutes containing carboxymethylcellulose or hydroxyethyl cellulose are more effective in relieving dryness than water-based or glycerin-based solutions. Prevention of radiation-induced cavities is best accomplished by aggressively using fluorides. Generally, acidulated fluorides are the most effective, although neutral fluorides may be more acceptable to patients with mucositis. Patients are instructed to rinse daily for 1 minute with 5 to 10 ml of a fluoride rinse. Stannous fluoride gels 0.4% or sodium fluoride gel 1.1% toothbrushing agents may also be used by patients to minimize their risk of caries. Meticulous attention to oral hygiene with regular dental checkups and avoidance of sucrose is essential to minimize the development of caries. In general, a dentist should see patients who will be receiving radiation therapy to the head and neck or chemotherapy agents with a high risk of oral complications before starting therapy. This includes patients with hematologic malignancies who will most likely experience severe myelosuppression for prolonged periods. Oral evaluation before therapy, intervention to eliminate potential sources of infection or irritation before therapy, and preventive measures taken during therapy can dramatically decrease the frequency of oral complications. Given BJB's risk factors, including the dose of radiation he will receive and concomitant therapy with cisplatin, a dental examination is indicated before initiating therapy. BJB successfully completed his first 2 weeks of combined chemotherapy and radiation therapy. However, 3 days into his 3rd week, he complains of generalized burning, discomfort, and pain on the ventral surface of his tongue. On clinical observation, both the ventral surface of his tongue and the floor of his mouth appear erythematous, and several discrete lesions are present in both areas. So my questions to you are: what is the most likely explanation for BJB's new onset of symptoms? What treatment is indicated at this time? Mucositis occurs as a nonspecific effect of chemotherapy and radiation therapy on the basal epithelium of the mouth. Non-keratinized mucosa is affected most often. Thus, the buccal, labial, and soft palate mucosa, the ventral surface of the tongue, and the floor of the mouth are the most common sites of involvement. Although lesions are usually discrete initially, they often progress to produce large areas of ulceration. The lesions typically do not progress outside the mouth, but they may extend to the esophagus and involve the entire gastrointestinal tract. The terms of stomatitis and oral mucositis may be used interchangeably. Mucositis may occur anywhere along the full gastrointestinal tract. Signs and symptoms generally occur about 5 to 7 days after chemotherapy or at almost any point during radiation therapy. The antimetabolites, e.g., methotrexate, fluorouracil, carfacetarbine, and cytarabine, and the anti-tumor antibiotics are the chemotherapy agents that most commonly produce direct effects on the epithelial cells of the gastrointestinal tract. Lesions generally regress and resolve completely in approximately 1 to 3 weeks, depending on their severity. Unlike oral toxicity seen with conventional chemotherapy, aphthous-like mucositis or stomatitis is a prevalent toxicity distinctly seen with mTOR, an abbreviation for mammalian target of rapamycin inhibitor therapy. Lesions typically appear during the first cycle of therapy, within the first week. Management often consists of supportive care measures and dose reductions. In severe cases, mucositis may require parenteral opioid analgesics for relief. Other signs or symptoms include decreased ability to eat and speak. Mucositis may be confused with an oral infection, particularly thrush, or mucositis and oral infections may occur concurrently. Local and systemic bacterial, fungal, or viral infections can occur and can cause a characteristic lesion. However, the lesion's appearance usually does not always correlate with the infectious agent. This particularly occurs in patients with neutropenia who cannot mount a full inflammatory response. In these individuals, the clinical appearance of an infected lesion may be muted relative to the presence or number of pathogens. Under normal conditions, the mucosa provides a natural barrier to the entry of normal oral flora, but the ulcerated mucosa allows pathogens access to the bloodstream. The patient could experience life-threatening infection or sepsis in addition to a local infection. We will now briefly look at treatments and prevention of mucositis. Treatment of mucositis is palliative. Topical anesthetics, including viscous lidocaine or diclonine hydrochloride 0.5% or 1%, are often recommended. Equal portions of lidocaine, diphenhydramine, and magnesium-containing or aluminum-containing antacids can be used for their anesthetic and astringent properties. Many institutions compound mouthwash products containing these ingredients as well as antibiotics, nystatin, or corticosteroids. Corticosteroids provide anti-inflammatory properties, and the antibiotics and antifungals provide antibacterial or antifungal properties. Another topical agent, sucralfate, may provide some benefit by coating the lesion and reducing discomfort. All of these topical products provide symptom control only, and data supporting superior efficacy of one product over another in relieving pain are lacking. Furthermore, these topical products are only effective in oral and throat lesions because lesions lower in the gastrointestinal tract are not reached with these local products. All the topical anesthetic-containing preparations are recommended for use as swish and spit preparations. Generally, 5 to 10 milliliters is used 3 to 6 times a day. The longer the patient can hold the solution in the mouth, the longer the contact, and, theoretically, the better the symptom relief. Therefore, patients should be advised to hold and swish the solution around the mouth for as long as possible before spitting it out. The risk of systemic effects from topical anesthetic preparations is slim if patients were to swallow them. However, large quantities swallowed could induce sedation and possible arrhythmias. Other palliative treatment options include topical benzocaine and ice chips. For small localized lesions, ointments such as benzocaine may be applied after the affected area has been dried with a sponge. Patients may also find ice chips soothing by allowing them to melt in their mouth. Most patients, however, require systemic analgesics to alleviate the pain. Gelclair is a bioadherent oral gel containing polyvinyl pyrrolidine, hyaluronic acid, and glycyrrhetinic acid, but no alcohol or anesthetic agent. It provides an adherent barrier over the mucosal surfaces, thereby shielding oral lesions from the effect of food, liquids, and saliva. Controlled clinical data are lacking. In a study of 20 patients with head and neck cancer undergoing radiation therapy presenting with mucositis, Gelclair was compared with standard of care, including sucralfate and lidocaine. No significant difference was found between the Gelclair and standard of care in relieving general pain. BJB appears to have a mild case of stomatitis or mucositis at this time. BJB should be encouraged to maintain good mouth care by keeping his mouth clean. Additionally, topical anesthetics are indicated for BJB topical lidocaine or a mixture of topical lidocaine with diphenhydramine and an antacid, 5 to 10 ml swish and spit 3 to 6 times a day, should be recommended. If the lesions progress during the next several days, systemic opioids may be necessary. BJB should also be carefully assessed for local infections within his mouth. My next question to you reads: could BJB's mucositis have been prevented? Historically, treatment of chemotherapy-induced and radiation-induced mucositis has been aimed at reducing symptoms once they occur and avoiding further trauma to the oral mucosa. Cryotherapy has been marginally effective in reducing the severity of chemotherapy-induced mucositis. Ice chips are placed in the mouth 5 minutes before chemotherapy begins and retained for 30 minutes. Theoretically, this will reduce blood flow to the mouth, thereby protecting the dividing cell population from toxins. Chlorhexidine gluconate 0.12% also may reduce the frequency and severity of mucositis infection, although not all studies have shown a benefit. This solution should be used twice daily as a rinse. Side effects include occasional burning, thought to be caused by the product's alcohol content, which can be reduced by diluting it with water, and superficial brown tooth staining, which polishes off easily. Chlorhexidine may reduce the frequency and severity of mucositis by eliminating microorganisms in the oral cavity. Despite these prophylactic measures, none of these aforementioned methods have a definitive benefit. To date, the only medication with proven efficacy is palifermin, a keratinocyte growth factor, approved for patients with hematologic malignancies undergoing hematopoietic cell transplantation to reduce the incidence and duration of severe oral mucositis. Other methods for decreasing the incidence and severity of mucositis symptoms include reducing the dose of radiation or cytotoxic therapy, but doing so comes at the risk of compromising treatment outcomes. Mucositis remains the dose-limiting toxicity for several anti-cancer regimens. Unfortunately, there are no prevention strategies that would reduce the chance of BJB experiencing mucositis from his chemotherapy and radiation, and thus, treatment for BJB is targeted toward relief of symptoms. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 424.